Hello, I'm Eddy Barasch and I'm a cardiologist at St. Francis Hospital in Roseland, New York in the Department of Cardiac Imaging. I thought it might be important to discuss the subtypes of aortic stenosis that one can see in clinical practice, how to diagnose them, what are their characteristics, and perhaps how to treat them. In severe aortic stenosis, in contrast with the normal valves, there is exuberant deposition of minerals, especially calcium, at the base and the mid portion of the aortic cusp, leaving the commissure largely unaffected. Aortic stenosis reached endemic proportions such that its prevalence is about 5% in individuals older than 65 years old, and the pooled prevalence for severe aortic stenosis reaches 3.4%. The rate of progression of disease is function of the initial calcium load on the valve, such that in mild aortic stenosis, the rate of progression is about 2 millimeter mercury per year, in contrast with severe aortic stenosis, where the rate of progression reaches around 5 millimeter mercury per year. So both baseline mean pressure gradient and baseline aortic valve calcium load are independent determinants of aortic valve progression. So as the disease is more severe, we expect to have a higher rate, a faster rate of progression than when the aortic stenosis is only mild or mild to moderate. A number of classifications have been proposed and have been adopted by the professional cardiology societies, both in the United States and in Europe. So the first one, which is familiar to everybody, is based on 4 parameters, meaning aortic jet velocity, mean gradient, aortic valve area, and velocity ratio, such that an aortic jet velocity in excess of 4 or equal to 4 meters per second, a mean gradient more than 40 millimeter mercury in a patient who had aortic valve area less than 1 and velocity ratio 0.25 stands for severe aortic stenosis. The index aortic valve area shouldn't be used in very obese individuals because we are overestimating the severity of stenosis. However, a newer classification have been proposed which takes into account the consequences of the left ventricular outflow tract obstruction by aortic stenosis. So 4 stages actually have been proposed, and you can see in these cartoons that stage 0, there is no cardiac damage. In stage 1, there is some left ventricular damage reflected in increased wall thickness and increased left ventricular mass. Left atrial pressure increases based on E prime ratio more than 14, and the left ventricular ejection fraction can drop less than 50%. The stage 2, there is left atrial or mitral valve damage. So the left atrium is enlarged, more than 34 milliliter per meter square. There is moderate or severe mitral regurgitation, and can be also aortic fibrillation. So any one of these echocardiographic findings put the patient at stage 2, in other words, at more advanced degree of left ventricular or left atrial damage. The stage 3, it's characterized by pulmonary vasculature or tricuspid valve damage, such that systolic pulmonary artery pressure increases above 60 millimeter mercury, and there is moderate or even severe tricuspid regurgitation in the absence of intrinsic tricuspid valve disease. And the stage 4, there is already right ventricular remodeling and systolic dysfunction. So from the left ventricular damage towards going backwards to left atrium, backwards to pulmonary vasculature, and to right ventricle, these are the consequences of severe aortic stenosis, which have been proposed by recently, and they have important prognostic value. The American College of Cardiology, American Heart Association, European Society of Cardiology, they embrace this classification or another classification of aortic stenosis, which is similar to that of heart failure. So stage A, it's patient at risk of aortic stenosis. Stage B, it's progressive. Stage C, it's asymptomatic but severe aortic stenosis. And stage D, symptomatic severe aortic stenosis. There are 4 variables here: the valve anatomy, valve hemodynamics, and hemodynamic consequences, and the symptoms. In stage A and B, there are no symptoms, patients asymptomatic, as in stage C also. However, in stage B, in aortic stenosis, there is, in progressive aortic stenosis, stage B, there is already mild or moderate aortic stenosis, as with hemodynamic consequences reflected in left ventricular diastolic dysfunction, but still normal ejection fraction. In stage C1, asymptomatic severe aortic stenosis, there is severe leaflet classifications with variables fitting the diagnosis of severe AS or very severe when the peak velocity it's equal or more than 5 meters per second, or the mean gradient equals or higher than 60 millimeter mercury. Again, there is this time presence of mild left ventricular hypertrophy, left ventricular diastolic dysfunction, ejection fraction is still normal, but in these patients it's recommended that exercise testing in order to confirm how really asymptomatic is a particular patient. In stage 2, C2, again asymptomatic, but this time already there is left ventricular systolic dysfunction. So the left ventricular ejection fraction less than 50%, and this is a class 1 indication for aortic valve replacement, even in asymptomatic patients in severe AS. Stage 3 comprises all 3 subcategories of symptomatic severe aortic stenosis. The first one, D1, is what we knew was that it's the only type of aortic stenosis, meaning severe aortic stenosis with high gradients and normal flow. There is concordance between the gradients, which is mean gradient equals or more than 40 millimeter mercury, and valve area less than 1 centimeter, square. These patients, in addition to in addition to left ventricular diastolic dysfunction, left ventricular hypertrophy, they can have pulmonary hypertension, and they are already symptomatic with exertional dyspnea, decreased exercise tolerance, exertional angina, or exertional syncope. Stage D2 is a classic low flow, low gradient, low EF AS that we knew also for many years, that brings poor prognosis. The valve anatomy is characterized by severe leaflet classification, and there is this discordance between the valve area, which is less than 0.1, less than 1 centimeter square, and the mean pressure gradient, which is less than 40 millimeter mercury. In this case, it's recommended a low-dose dobutamine stress echo to determine if the patient has pseudo or severe aortic stenosis. The ejection fraction is less than 50. Left ventricular hypertrophy, diastolic dysfunction might be present, and the patients have not only exertional symptoms, but even at rest, they can have angina and they can develop syncope or heart failure. The stage D3, it's a relatively new stage, and patients are symptomatic. They have severe aortic stenosis, but they have low gradients and low flow normal 11th ejection fraction. And this is a paradoxical low flow severe AS. The valve anatomy shows severe calcification, and there is discrepancy between the valve area, which is less than 1 centimeter square, and the gradients, which are less than 40. And there is a stroke volume index reduced to less than 35 milliliter per meter square. And this diagnosis should be made when the patient is normotensive. The hemodynamic consequences show an increase in left ventricular relative wall thickness and a small left ventricular chamber due to left ventricular hypertrophy, restricted diastolic filling, and the ejection fraction is equal or more than 50%. There is also a stage D4, which didn't make it into the guidelines, which is a normal flow, low gradient, normally have severe aortic stenosis, which manifests basically like moderate aortic stenosis. So more than 50 years ago, Dr. Braunwald wrote that an invasive transvalvular pressure gradient less than 50 millimeter mercury in patients with preserved left ventricular systolic function is considered to reflect non-significant aortic stenosis. Ironically, more than 50 years afterwards, in 2007, Dr. Vahanian and his colleagues from Europe, they wrote that severe AS is unlikely if cardiac output is normal and there is a mean pressure gradient less than 50. So this is a category of normal flow, low gradient aortic stenosis with a reject that can be severe. So let me give you two examples. One is a 68 years old female with an ejection fraction of 58%, stroke volume index 43 milliliter per meter square, a calculated aortic valve area 0.5, with a peak and mean gradient of 129 and 83 millimeter mercury respectively. So this is a classic normal flow, high gradient, severe aortic stenosis. Stroke volume is more than 35, mean gradient is more than 40, and the valve area is less than 1. One can see here the parasternal long axis, short axis, and the spectral display of continuous wave Doppler through the aortic valve. The second example is an 84 years old male with ejection fraction of 63, stroke volume index 31 millimeter per meter square, aortic valve area 0.6 with a mean gradient of 21 millimeter mercury. So this case, in spite of the fact that the valve area is 0.6 and severe AS, ejection fraction is normal, has a low stroke volume, less than 35, and a low mean gradient, less than 40, and still it's severe aortic stenosis. So this is an example of low flow, low gradient, normally you have paradoxical aortic stenosis. One can understand that the explanation for it resides in the fact that normal ventricular ejection fraction does not mean necessarily a normal stroke volume, which some of us have difficulties understanding it. So this is an example of severe aortic stenosis from a paper of Dr. P. Barasch and Dumenil. Normal flow aortic stenosis, left ventricular end diastolic volume, 150 milliliters, ejection fraction 60, the stroke volume is 70 milliliters, aortic valve area 0.7, and mean gradient 45 millimeter mercury. In a patient who has paradoxical low flow aortic stenosis, you may observe in this cartoon that the thickness of the left ventricle walls is increased, so they has left ventricular hypertrophy. So therefore, the cavity size is smaller. Left ventricular end diastolic volume is only 85 milliliters, and the left ventricular ejection fraction is still normal, 60. But the stroke volume is only 50 milliliters, in spite of the fact that valve area is 0.7 and the mean pressure gradient 25 millimeter mercury. So for an identical ejection fraction and valve area, in first example, we see that the stroke volume and the mean gradients are according to the guidelines which diagnose severe AS, in other words, the stroke volume of 70, which will be about 35 milliliter per meter square stroke volume index, and mean gradient 45. And the second example, the stroke volume is diminished, and consequently, the pressure gradient is low. But even so, the aortic valve, calculate the aortic valve area, it's 0.7. And this is a presence, again, with normal ejection fraction. One of the problems that resides from the fact, and this was explained by Dr. Carabello in his lab in invasive methods measuring the pressure gradients and the valve area, that if one plots the mean pressure gradients here on x-axis against the valve area on y-axis and put the limit, the threshold for severe AS as 1 centimeter square valve area and 40 millimeter mercury mean pressure gradient, there is no linear relationship but curvilinear, and such that at 1 centimeter square aortic valve area actually will correspond to 26 millimeter mercury mean gradient, not to 40. So this is in built-in discrepancy in the guidelines. And if one look at the raw data, you can show here that indeed 1 centimeter corresponds to 26 and 0.8 to 41. But there are a number of papers showing that these patients with valve area between 0.8 and 1, they are doing the same. In other words, the prognosis is similar to those who have a valve area less than 0.8. So therefore, the threshold for severe AS has been modified if for those a little bit older from 0.8 to 1 centimeter square about 15 years ago. So in patients who have normal ejection fraction and aortic valve area less than 1 centimeter square, one should take into consideration both the stroke volume index and mean gradient in order to categorize these patients. So Dr. Dumenil and P. Barasch, they published 10 years ago, more than 10 years ago already, this data. And since then, we are talking about these 4 hemodynamic groups of severe aortic stenosis. The first one is a classic aortic stenosis, so patients who have normal flow and high gradients. Normal flow, again, more than 35 milliliter per meter square stroke volume index, and mean gradient in excess of 40 millimeter mercury. Those who have low flow, low gradient, still normal EF, they are those who have paradoxical low flow, low gradient aortic stenosis. Normal EF, valve area less than 1, mean gradient less than 40, and stroke volume index less than 35. The third category are patients who have also normal flow but low gradient, and they manifest mostly like patients with moderate aortic stenosis. Actually, we will discuss this in this next lecture. And the fourth group, it's low flow and high gradient. These patients have been recently recognized to have a worse prognosis than those patients who have normal flow and high gradients. So in the upper quadrants, there are patients with normal flow, low and high gradients. In the lower quadrants are patients with low flow, low gradient, and high gradients. The clinical manifestations of these four categories will be discussed in the next lecture. Thank you for your attention.